Hello, and welcome to this month's case study presentation, the Obesity Metabolome Connection to Breast Cancer. This is a case study featuring a perimenopausal woman who's in for support for weight loss. You know, like half of your patients probably. I am Dr. Allison Smith. Oh, I'll be leading this discussion today. I'm a naturopathic doctor. I've spent a number of years in primary care and patient care. I've been in the laboratory space for almost 10 years now, looked at probably thousands of lab reports, maybe tens of thousands of lab reports in that time. I always hope to bring a lot of that experience forward and have great conversations with people where I always say people walk away feeling smarter, like all of us do. So today's plan is essentially to present this case of a 49-year-old perimenopausal white female with a lifetime of obesity. And she has basically one goal, and she really wants to take charge of her body composition. I think, she's somebody who otherwise feels pretty healthy. She leads an active lifestyle, feels like she has a pretty fantastic diet, and feels like she's done all the things, and has been, sort of frustrated to not match that lifestyle that she's sort of put forth in her life. So she's really here to figure out how she can get her body to match up with how she feels. So I want to introduce the hormone metabolome of obesity, and what metabolic obesity looks like on the Dutch, which is essentially giving you that hormone metabolome information. And to introduce obesity as that independent risk factor for breast cancer development, because it is October and everyone's thinking about breast cancer and their moms and sisters and aunts, and we want to honor these folks who are survivors and those who will go through breast cancer diagnosis and treatment in their lives, and hopefully decrease everyone's risk of breast cancer by looking ahead 10 years, by looking at the hormone metabolome ahead of time and maybe making some changes. So we'll also go over what they did to address the chief goal of weight loss and how they may have ultimately prevented a breast cancer case down the road, hopefully. All right, here's our disclaimer. This video is not providing medical advice, but just a reminder. These are all sort of ideas, and always treat the patient in front of you. All right, I'm going to start with some stats. Obesity. It's almost half of our nation, essentially. We're really, with Black Americans, we're at almost 50%. White Americans, 40%. Hispanic Americans, 45%. We're really just about half of our nation suffer from obesity. And we know that obesity contributes to chronic diseases, type 2 diabetes. It lends itself to cardiovascular disease and cardiovascular events. It makes us more susceptible to negative consequences of COVID. And, we've been reintroduced to some of the issues with obesity even recently, with what we've gone through with COVID. So I feel like, as the prevalence of obesity grows in this country, the risk of hormonal cancers will increase. And we have this golden opportunity, or really golden responsibility, to keep that from happening. And when we talk about obesity, we have to know that many times we're talking about metabolic obesity that's really only visible in the lab work. Some people call this, the skinny fat patient. And we may not be able to just tell by looking at somebody quickly during an encounter, or even trying to rely on BMI as the sole clue. If anything, I think as a field, I think we're trying to come away from using BMI at all and to go towards using things like waist circumference and, some of these other, and I'm not going to spend a whole lot of time on diagnosing obesity, because I think the idea is that, if we see some of these metabolic obesity changes, in the lab work, that it's our responsibility to get after the underlying inflammation, the insulin insensitivity, immune activation, whatever is underneath there that's setting people up for obesity complications down the road. So I guess that kind of leads us to the next question. Can weight loss, if you have somebody who's in for weight loss, can that weight loss, if they're able to attain that, can it prevent a postmenopausal breast cancer down the road? I think the medical literature is pretty much a resounding yes. When you look at observational studies, at least, and there is one study from the Women's Health Initiative data that felt like weight loss wasn't necessarily going to decrease somebody's risk of breast cancer. But most of the observational studies are saying, yeah, and especially if you can sustain that weight loss over time, you can certainly have, lower incidence of breast cancer down the road. Even studies that have been done on bariatric surgery patients, those guys have a lower risk of breast cancer on the other side of bariatric surgery. With all the problems with bariatric surgery, I think all of us are looking for other options. That's not the best for people. I think bariatric surgery can lead people down a terrible path with bone loss and early mortality. There's problems there. So obviously we want to do other things if we can, but even if that's the only way, people can still end up on the other side with a lower risk of cancer down the road. So the hormonal milieu of obesity is connected with that of breast cancer. The estrogen dominance, the dysbiosis, the leptin and insulin resistance, the estrogen metabolic patterns that can favor genotoxic phase 1 metabolites and pro-inflammatory environment, like all together kind of leads to oxidative stress damage to the DNA. And this all opens the door to cancer initiation, growth, and spread. So we really want to keep in mind all of that sort of oxidative stress, inflammation piece that we see with obesity, and certainly that metabolic obesity, and definitely expect that if we can quell a lot of that fire, that we can decrease breast cancer risk, hopefully. In fact, at the level of lifestyle, obesity and breast cancer share some common risk factors. And, some of these may be no-brainers, like sitting 10 plus hours a day. There's a study for that. Red and lunch meats, maybe that makes sense to some people. But there's, if you look up, I have a little risk convergence picture here. If you essentially look up a study on red meat and obesity risk, you'll also find a red meat and breast cancer risk study. And here's a sedentary behavior and physical inactivity leading to obesity. And here's one on the same thing and breast cancer. And look at this, light at night, during sleep disturbance in obesity, and then that leading to breast cancer. So really, they share so many of the same sort of risk factors, and they really converge here. So I thought this was a really great way to kind of introduce that concept. Dysbiosis leading to obesity, dysbiosis leading to breast cancer. So you treat one, you're kind of treating the other. And because obesity often precedes breast cancer, we could utilize some of these supports to hopefully decrease risk. All right. We all like the thought of being preventive with weight loss, preventing cardiovascular events, preventing diabetes, and we're preventing maybe having to spend thousands, if not, $1 million down the road in medical costs and heartache and, all of the stuff people have to go through to deal with chronic disease, and how much it would cost to go through a cancer diagnosis. And we can add that maybe to the list of preventables here. But there are 4 areas of focus on the Dutch when we're assessing someone to figure out where to start for weight management support so that we can treat that whole patient. With the Dutch test, when it comes to obesity, from my perspective, we're really looking at 4 sides of the story. One side, see if I can give you a laser pointer here. One side, we're really looking at hormone levels, right? High estrogens in circulation, high androgens in circulation, a lot of good research on hormone levels and their relationship with breast cancer development down the road. DHEA metabolites, all that aromatase activity leading to estrogens, hormone levels. And then we've got the second side, which is the metabolic pattern. So how estrogens are metabolized. You know, we'll talk more about that, but the phase 1 metabolism of estrogen is the hydroxylation reaction, essentially. And there's 3 different carbons that that hydroxyl group, in order to get this thing water soluble, really is a hydroxylation. And where that carbon is, where the hydroxyl group lands, is going to determine how stable that structure is. And some of the metabolites of estrogen are very unstable by structure. And so with obesity, there's a pretty specific pattern that we see that we'll go over. But that's the metabolism patterns. And then adipose tissue makes a lot of cortisol. And one of the things that the Dutch test looks at that's unique, I think, are these cortisol metabolites. And we can't necessarily say that all the cortisol metabolites that we're looking at on the Dutch test are coming from adipose tissue. We couldn't say that. The adipose tissue, though, if you have a significant amount of adipose tissue that is centrally distributed, I think we could certainly say that it's a big contributor. But a fair amount of the cortisol metabolites are coming from the liver as well, and also from other tissues. So when we see very high cortisol metabolites, we know that there's a big contribution from adipose tissue, and that suggests that 11 beta HSD1 activity is high, generating cortisol from inactive cortisone from circulation, and that sort of extra adrenal synthesis of cortisol is evident on a Dutch test, and maybe I think we'll find extremely correlated with breast cancer risk. And then the fourth side is oxidative stress and inflammation. So we want to make sure that we're assessing that terrain of inflammation and oxidative stress, which can make it more favorable for DNA damage to occur. So really shoring up that side of things. And I think everything else on the Dutch test is icing on the cake. All right. Next slide. There we go. All right, so you will notice that in each wedge here, so hormone levels, there are specific Dutch analytes that speak directly. And what I've tried to do, and hopefully you guys will download some of these slides so that you can have these. But the idea is that, if we're looking at hormone levels, these are what we're looking for. Testosterone and its metabolite, dihydrotestosterone, some of the DHEA metabolites like androsterone, and some of the 4-hydroxyestrogen metabolites. And then for the metabolic patterns, we have some things to look for here. In the adipose cortisol metabolites, high metabolites of cortisone, so tetrahydrocortisone or THE, tetrahydrocortisol or THF, and 5-alpha tetrahydrocortisol. Those are all, when they're elevated in the urine or show a doubling in the urine over time, that can constitute a higher risk of breast cancer, according to a study I'm going to present during this case. So anyway, high 11 beta HSD1 activity also correlates with high leptin levels, which we often see a leptin resistance in patients with who are struggling with obesity. So really focusing here can make a big difference for not only the way adipose tissue functions, if you're able to successfully treat that high 11 beta HSD1 activity to help people lose the weight, then you can go after leptin and leptin resistance. Oxidative stress and inflammation, we're really looking at 8-OHDG, which is it's actually a marker of DNA damage that ends up in the urine after a period of oxidative stress and high cell turnover. And that can be important to look at as a way of assessing that oxidative damage. High pyroglutamate can tell us about low glutathione or high need for glutathione that's maybe unmet. And quinolinate and kynurenate, quin and kyne, When quin is high compared to kine, it can tell us about neuroinflammation and inflammation in general, systemic inflammation as well. But when kine and quin are both elevated at the same time and sort of not necessarily at a higher ratio, it can tell us about insulin resistance and sort of systemic inflammation as well. So we'll want to look at that pretty closely. I have some cool information on quin and kine for breast cancer and obesity to share. And then, of course, cortisol and metabolites of cortisol can be a big sign of inflammation and stress, since cortisol is our big stress hormone and anti-inflammatory hormone. So when we're looking at labs for an assessment of somebody who's here for weight loss, we really want to look at their fasting insulin and their glucose and their A1C. We really want to get a sense of their insulin handling. We want to look at their lipid profile. We want to look at sex hormone binding globulin. Is it really, really low? Do they have a high, free circulating level of sex hormones? Phase 1 estrogen metabolites favoring 4-hydroxys. And I think this is pretty well fleshed out in the medical literature at this point. But these are the ones that you don't want to be a predominant species. And when they are, they can lead to DNA damage and initiation of cancerous processes, especially when if you have a genetic sort of makeup that doesn't allow you to fix that damage. High inflammatory markers like hsCRP, some people will do interleukin-6 and TNF-alpha. You could really do a full inflammatory panel if you wanted to, but hsCRP is probably the most common one we'll see people coming in with. High serum leptin, indicating leptin resistance. And in the urine, we look at the metabolites of cortisol. We look at the metabolites of the androgens like dihydrotestosterone and androsterone, as they are 5-alpha reductase metabolites. And of course, high urinary xan, kine, and quin, as we kind of alluded to in the last slide. Stool testing, I didn't include here, but I think stool testing for patients who are struggling with obesity can be really, really beneficial. You may find that reveals dysbiosis or low levels of akkermansia. It's being talked about, or at least bandied about more in the medical community. So do think about the microbiome. There's more and more research on dysbiosis and dysfunctional, essentially short chain fatty acid generation from the gut. And we really need short chain fatty acids in the right ratios at the liver and the adipose tissue to turn on and turn off 11 beta HSD type 1. So there can be an influence from gut dysbiosis that may influence us to hang on to fat and make our own extra adrenal cortisol in fat tissue to keep us dysfunctional in our adipose tissue function. So don't forget the gut, don't forget the stool. High circulating levels of estrogens and high aromatase activity put women at higher risk than men in general. I think women get breast cancer 100 times more often than men do. I mean, it's some ridiculous statistic like that, but don't quote me. But it is much higher in women. And phase 1 detox abnormalities we find in adipose tissue with upregulated CYP1B1 expression and higher 4-hydroxy metabolites. They can become genotoxic. So these guys are tip top of the list of things to check out here. Let's see. There we go. CYP1B1 upregulation, high 4-hydroxyestradiol, and really 4-OHE2 is worse than 4-OHE1. So when you go down the Dutch report, and you sometimes we'll skip over page 2 and we'll just go right to page 3 and we'll look over the the picture page. The 4-hydroxy estradiol metabolite doesn't show up there. In fact, just the estrone metabolites show up on page 3. So do flip back to page 2. We do report a 4-hydroxy E2. So just, get your highlighter out and highlight it, because some people are elevated in their 4-hydroxy estradiol, even when their 4-hydroxy-E1 is within normal range. And when you see high 4-OHE2, that may be somebody who's at higher risk. The 4-OHE2 is less stable and more likely to form a reactive quinone and form a DNA adduct than the 4-OHE1 even. Phase 2 detox, we think about as our big methylation system. It's utilizing COMT, which is a methyltransferase enzyme that requires SAMe and a double cation like magnesium, and B6 always holds hands with magnesium and all of its cofactor activities. So, making sure that COMT activity is adequate to continue those hydroxylated metabolites on down into water solubility and to elimination, hopefully in phase 3. I stuck glutathione here too in phase 2 because it is another way that we can neutralize our phase 1 metabolites and keep them from damaging the DNA, similar to methylation. And there are, some SNPs that keep us from being able to glutathionate properly, just like SNPs that may make it difficult for us to methylate properly. Phase 3 detox, we're not really looking at on a Dutch test, but you can assess somebody's elimination sometimes by getting a good digestive history on them. You can do stool testing. You can look for organisms that are high beta-glucuronidase producing organisms. Beta-glucuronidase is essentially an enzyme that is made by some parts of our microbiome that when they are overgrown, this particular enzyme can cleave the glucuronide group off of estradiol and estrone and allow us to reabsorb those estrogens from the GI and recirculate them and redistribute them and remetabolize them and increase our risk of, estrogenic issues, including maybe increasing our risk for breast cancer and obesity. All right, so the focus has really been on estrogens historically with breast cancer, and it still is, a lifetime of higher estrogens. If you don't have breaks in high estrogens, they think of if you have kids earlier in your life and you have longer breaks of away from estrogens, that maybe that confers a more protection from breast cancer, and but very much focused on estrogen as kind of the big bad guy. But there may be other parts of the steroid metabolome that are also associated with development of obesity and breast cancer, and they are the cortisol metabolites, maybe not surprisingly, and some of the DHEA metabolites as well. So I want to share this study with you because I didn't even know it existed. It's called The Steroid Metabolome and Breast Cancer Risk in Women with a History of Breast Cancer. So they're really looking at, estrogens, progestogens, the testosterone and its metabolites, DHEA and its metabolites, and all the cortisol metabolites. And this is an open access paper, so you can Google it or go to PubMed and find it, read it in its entirety. But it is really all about urine hormone metabolites and the rises in which ones are associated with breast cancer development. And it's in a specific cohort. It's in female patients with a family history of breast cancer. And some of them are premenopausal. I think it's 65 or 66% of all the women in the study are premenopausal, and then the rest are postmenopausal. So it's kind of a mixed cohort. I think they did split out the cohorts as well, so you can have a look and see how it's helpful to you or not. But I pulled out some interesting pieces here. Some of the findings really might surprise you. I was a little surprised. I was floored to read that tetrahydrocortisone, tetrahydrocortisol, and alpha tetrahydrocortisol, all three of these metabolites we actually report on the Dutch test, and when they're high, kind of looks like this in the dial. We're very elevated metabolites of cortisol. The increase in these cortisol metabolites, or a doubling of these cortisol metabolites, constituted a pretty high, 161%, 116%, and 75% respectively increased risk. Anyway, that's pretty significant. So if we're looking at somebody with high urinary metabolites of cortisol, we should be thinking about, oh no, this is risky. This is, telling us about inflammation and oxidative stress and insulin insensitivity, and maybe insulin is a huge driver here. Insulin is our workaround for when we can't get glucose into the tissue, and cortisol can go right to the DNA and upregulate genes that control gluconeogenesis and glycogenolysis, and insulin's big driver of metabolized cortisol. So there's a number of things here we can go after to decrease this risk. And then the other side is DHEA metabolites like androstenedione and androsterone being implicated in higher risk as well. So on the Dutch test on page 3, you have your DHEA coming down into androstenedione. Neither of these are we testing, but we look at the downstream metabolites of DHEA, and we do look at DHEA sulfate. And I think between those three things, you can get a sense of how much androstenedione is around, and we can certainly look at androsterone levels and that preference towards the 5-alpha metabolites that I think are somewhat riskier when we're looking at the urinary levels. All right. Surprise finding. Okay. So in this mostly premenopausal cohort, remember, a doubling of urinary estrogens, you would think, would increase the risk, but in fact, actually decrease the risk significantly. So when we're thinking about the risky things on a Dutch test, are increasing cortisol metabolites, increasing DHEA metabolites, not so much increasing estrogen metabolites. Let that sink in. That is surprising, because the opposite is kind of true when we think about estrogen estrogen circulating in the serum. If you have elevated serum estrogens for much of the time, then that confers a higher risk. So urinary might be telling a different story. Progesterone metabolites were basically equivocal, kind of non-significant increase in breast cancer risk when they're doubling, but it did not reach significance. So it's not really telling the story. Beyond sex hormones, there are oxidative stress markers and organic acids to think about too. And I just wanted to talk about the tryptophan metabolism for a minute. When tryptophan is highly metabolized down the kynurenine pathway, that's a sign. It can be a sign of trouble. It can be a sign of a high need for NAD. Maybe we have a deficiency in niacin, and we're trying to reach, more or de novo synthesize more niacin and NAD. We have the ability to do that. But research on kynurenate and quinolinate, kine and quin in the urine, suggests that when they're high, it's a sign of increased IDO1 enzyme activity. It's led to kynurenine formation in adipose tissue. So in adipose tissue, this enzyme gets upregulated significantly, and you get more formation of kine and xan, especially when you're low in B6. So we always want to look at, in somebody who has metabolic obesity, we always want to look at kine and xan, because if that person is low in B6 and they're funneling lots of metabolism down this kynurenine pathway, they're going to get stuck at kine and xan. And when kine and xan increase certainly in the bloodstream, especially xanthionate can form these complexes with insulin, which essentially gloms onto it and doesn't allow it to bind its insulin receptors. And we end up perpetuating a kind of a physical insulin resistance that requires, zinc and B6 in order to kind of get that reversible reaction reversed and insulin freed from xanthionate. But so we always like to look at this, because that can give you some avenues and help people respond to their treatments for insulin resistance a lot better and get them replete in their B6. And then the second thing we like to look at is quinolinate, because quin, when it's elevated, suggests inflammation. I think in some types of obesity, there's a lot of inflammation that sometimes flies under the radar. Just maybe the HSCRP is normal. Maybe there aren't a lot of signs, but this super high Quin compared to Kine, that could be a big sign that there's some inflammation that hasn't been dealt with. It'll give you an opportunity to get after that. So Kine and Zan are associated with obesity and with breast cancer. The Quin-Kine ratio may be high in inflammation. It can indicate pro-tumor activity. So all reasons we really like to keep these guys in check if we can. Oxidative stress markers are kind of no-brainers. I mean, not surprisingly, insufficient glutathione activity can lead to oxidative stress damage to the DNA. So when pyroglutamate is high, eventually 8-OHDG is probably going to be high. It kind of kicks the door open for increased risk of cancer if there's inefficient DNA repair. And that almost requires a like a genetic component or some sort of deficient component to go from high 8-OHDG to cancer. That's a jump. But I think whenever we see 8-OHDG, we always want to make sure that we have adequate glutathione precursors and that we get that activity up so that we're doing a better job at protecting the DNA and making sure people are eating enough reds and greens and getting enough micronutrition as antioxidant supports. All right, here's our case. This is really what we're here for, right? Let's chat through our case. So this patient is not here for breast cancer prevention at all, specifically. She has found us because she's looking for help in losing weight, and she's been weight loss resistant her whole life. So her chief goal is sustained weight loss. That's what she really wants. She's dealt with the disease of obesity for much of her life. She's 5'6". She's 300 pounds, and she's always kind of been, since she was a teenager, in this 300-pound territory. Her waist is 58 inches. She has 2 grown children. She lives with a partner, and she is employed as a florist. She swims 5 days a week, and she is busy. Like, she includes resistance. She does aerobics. She's on it. And on it every day. And, she's in the pool for almost an hour a day doing this. She eats a Mediterranean style diet. She's careful about her carb intake. She does an occasional glass of wine, but maybe once a month. So it's very occasional. So not really somebody who drinks much alcohol. Her family history is positive for colon cancer, but no other cancers that she's aware of. Her cycles have become irregular just recently. Her last menstrual period was about maybe a little bit more than 3 months ago. And this is kind of new. This is a new irregularity, and she thinks she might be going through menopause soon. But she does deny typical menopausal symptoms, no hot flashes or night sweats or vaginal dryness. But she's noticed some hirsutism in the last year or so. Her meds include metformin. She just does 1,000 milligram dose, and she does an omeprazole for GERD. And she's currently managed by a primary care physician who is working on her to consider bariatric surgery, which she's really not interested in doing. So she was hoping to get the support that she needs. She's read about some of the new medications that have come out that are geared towards weight loss, some of the newer pharmacotherapies, and she's very interested in doing whatever it takes to avoid bariatric surgery. So some pertinent serum lab findings: she had an elevated fasting insulin glucose, but in the pre-diabetic ranges. She has an elevated HSCRP. She had a high for HDHEA sulfate of 250, so her range would go up to 244, so maybe just a little bit high, and maybe kind of due to that insulin picture. Her SHBG is low, consistent with metabolic syndrome. Elevated leptin, cholesterol, and triglycerides were mildly elevated, and they had ordered an advanced lipid profile with the results that were pending. Thyroid panel is within normal limits. And so this provider ordered a Dutch Complete. And this is what it looked like. Page 1 of the Dutch Complete report is basically a summary page. So we're looking at levels of everything. Levels of estradiol, levels of progesterone, levels of testosterone, and we get a preview of cortisol metabolism. For this patient, we see already that she has a relative estrogen dominance, right? Relative estrogen dominance. I wonder if I have a little visual here. Do I? No. Yes, there it is. Relative estrogen dominance. You can see her progesterone is low, her estradiol is within normal range. She certainly doesn't have high estrogen, but you don't have to have high estrogen to have it be the dominant species when progesterone is anovulatory. So it doesn't really look like she's ovulating. Is she heading towards menopause? Maybe. I think sometimes people will call in and say, hey, does this patient look like she's menopausal? Because her estrogens are where they are, I don't think you could say for sure that this patient is menopausal. We could say that she had a period 3 months ago, so she's technically not menopausal. You could, in a few months, pull an FSH and see, if she's climbing up into the 60s or 70s or 80s or 90s. Yeah, I mean, it's imminent. It's happening. She's 49. She's on her way, but she's not there yet. Testosterone we think of on an age range. So even though she's within the big, human female range of 2.3 to 14, 9 is a little high for somebody who's 49. So we usually top out at 8 when we're 49. So that already seems like a little on the high end. And then for DHEA production, the total DHEA production is a conglomeration of 3 DHEA metabolites. One is DHEA sulfate, and then the other 2 are androsterone and etiocalanolone, which are the downstream metabolites of DHEA. And when we add those together for her, she's a little high. For her age range, she should top out at 2,000. So overall, she's a little on the high end. And that total DHEA being a little high matches up pretty nicely with her serum DHEA sulfate, which was 250 on a range that goes up to 244. So that's pretty consistent. Free cortisol is within range. High normal, I guess, if we're being picky. But overall, she's got a pretty normal area under the curve, maybe a little high. And it's the right shape. She's waking up and has a nice rise in cortisol that's a lot higher than her nighttime level. So from a resilience point of view, this looks pretty healthy, and maybe it's why she's not presenting with a lot of fatigue and burnout and distress, is that she does have this cortisol pattern that's pretty preserved for somebody who has such a high metabolism of cortisol. So this is really the marker that jumps off the page here. Let's see. I'm not keeping up with my discussion. Sorry about that. This is the one that's jumping off the page. The high metabolized cortisol, nearly twice again the top end of the normal expected range. So we'll talk a little bit about what that means to us clinically. But remember, those cortisol metabolites may be putting her at risk, or maybe a sign of risk of breast cancer, possibly. Page 2 of the Dutch report gives us a little preview of what we're going to see on the dials on page 3. And remember, sometimes people will flip past this page and miss some of the information on it. Because she's here for weight loss and she has some insulin resistance showing up in her lab work, and her testosterone and total DHEA were a little bit high, and she's got that hirsutism, remember, in the clinical presentation. It does make sense to look at her androgens really closely. And I just highlighted them here so you could find them in this laundry list here. But in the androgen section, underneath testosterone, you'll find 2 metabolites. Dihydrotestosterone is high normal at 5.46. And for somebody who's 49, that's a pretty goodly DHT. Sometimes in perimenopause, LH levels are rising and you have, theca cell stimulation, and it's not a super unusual time to see dihydrotestosterone and 5-alpha andro elevated. Doesn't mean that it feels good or looks good, but it can be just kind of a sign of perimenopause. And if she's been having that, increase for the last year or so, but maybe that she's kind of been in perimenopause for a while. Maybe that's all we're seeing here. But it seems significant given her hirsutism and her insulin driver of 5-alpha activity going to increase the formation of these metabolites. And you can use, kind of band-aid therapies that slow down 5-alpha reductase and can help with that hirsutism. Think about saw palmetto and pygeum, nettle root, green tea, reishi, lots of ways to slow down that testosterone conversion down into the 5-alpha metabolites. The page 3 of the report is kind of where the rubber meets the road for sex hormones. A lot of what's on page 2 ends up on page 3, and we can really see it in the metabolism pathways, kind of in their natural state. So we've got her. What do we start with here? We've got our estrogens on the right-hand side of the page. So if we zero in on the estrogen metabolism here, what I've kind of highlighted, we do see phase 1 and phase 2 depicted here. And in obesity, we know the CYP1B1 is highly expressed. So we want to look for the 4-hydroxy estrogen. That doesn't look elevated, but it is higher and it's in the luteal range than certainly the 2-hydroxy. These are the two that we really scrutinize together. We want the 2-hydroxy to be the dominant species, and significantly so. And one good way to look at this, quick look at the pie chart kind of confirms that she's putting a little too much stock down this 4-hydroxy pathway. All right. So we know that our phase 1 metabolism activity is a little bit aberrant. And what drives this CYP1B1 activity, and probably why we see it more expressed in fat tissue, is that inflammation drives CYP1B1 activity. So that could be one area that we could address, inflammation, to bring this 4-hydroxy estrogen predominance down. I know sometimes we just kind of knee jerk to DIM or indole 3-carbinol or sulforaphane, and you absolutely can go that route, and they do upregulate the 2-hydroxy pathways, and you can get there. But if it really is inflammation that's driving a lot of this picture, and we know that, we don't have to use therapies that are non-specific. We can go right after it. To assess phase 2, we like to look at the difference between the 2-hydroxy and the 2-methoxy. And what we're looking for there is about a 2-to-1 ratio of the 2-hydroxy to the 2-methoxy. And she's better than that. So she's got a nice high COMT activity. So phase 1, phase 2 looks pretty good. So progesterone up here in the corner is not very exciting, so I didn't color it anything, but the alpha and beta pregnenolones are both hanging around the postmenopausal ranges. She's got a pretty strong 5-alpha reductase preference, so you can see the beta pregnenolone falling below its normal range, while the alpha pregnenolone is enjoying being in the range. Some folks who are kind of going through perimenopausal transition enjoy some progesterone replacement therapy when they're symptomatic. This patient doesn't really seem to have any symptoms at the moment. So, kind of optional to even consider it in the first place. But patients who have a lot of sleep problems or anxiety problems, or I don't know, they tend to do really well with progesterone support during the perimenopausal transition. And as cycles get irregular, you can be more continuous with your dosing rather than trying to just dose it during the luteal phase. So that brings us to the androgens, which I have in purple here. Androgens, we know her testosterone metabolites were high, but let's look at her DHEA metabolites. So here on page 3, remember on page 1, we had the total DHEA production, which was essentially DHEA sulfate added together with etiocholanolone and androsterone, all in one number, all in one range, right? Here they're teased out into their component parts, and we can see, DHEA is made in the adrenal glands based on ACTH stimulation. and insulin and prolactin. And there's some independent drivers of DHEA production outside of ACTH, but ACTH is probably the biggest driver of DHEA production. And that DHEA gets sulfated locally and in the liver. And we're not seeing a lot of DHEA sulfate production, interestingly. So that strikes us as a little bit odd. So DHEA sulfate of 37, and she's in this 30 to 350 category here. 37, that's pretty low for sulfation compared to her downstream metabolite of DHEA, the alpha androsterone. Her range should go up to 1,000. She's at 1491. You can just kind of see where her DHEA is going, not to the sulfated form as much as it is the downstream metabolite. And just a note, I made a mention of it on when we were talking about page 1, but urinary androsterone correlates more strongly with DHEA sulfate in the serum than does DHEA sulfate in the urine. So when you're trying to do a side-by-side comparison of your serum results for DHEA sulfate, do look at androsterone levels and do look at total DHEA production on page 1. They should correlate up pretty nicely. And finally, we want to look at her 5-alpha reductase predominance. We can see that pretty strongly. 5-alpha reductase gets upregulated by inflammation. I mean, you can kind of see this inflammation picture starting to emerge. Inflammation blocks sulfation. Inflammation drives 5-alpha reductase. Inflammation drives CYP1B1. You can kind of see these patterns. Once you learn them, you can go, oh, I think I know, a unifying theme here. All right, so now that we've marked up the sex hormones page, let's look closely at adrenal page 5. Page 4 is all the data that goes on to page 5. So often we'll kind of skip over and focus in on the picture page. It's easier to look at the diurnal patterns on the graphical format. And a couple things new that we've kind of cemented down. We saw a little glimmer of it on page 1 with the cortisol pattern, right? That was at the tip top of the range, but not quite elevated. And the metabolized cortisol that was very high. But we have a couple pieces of new information here that we want to synthesize in. So let's dig into the cortisols. We did talk about the DHEA. Some of this really is a repeat from page 1. So the daily free cortisol and cortisone patterns, let's start there. These guys. Yeah, daily free cortisol, cortisone. The right diurnal shape, right? She's looks pretty good here, but she's tip top of the range. And if we look at cortisone, she is in fact elevated. And where is this happening? It would be the first question. So a lot of people will say, well, why does she favor cortisone in the free cortisone, but in the cortisol metabolites she favors, cortisol metabolites? How can that happen in the same person at the same time? And here's my answer. These are two very different tissues. So the free cortisol is converting to free cortisone locally in the renal tubule within the kidney before it hits, the bladder or has entered the urine and hits the bladder. And so when we're looking at cortisol conversion to cortisone, and what the kidney needs cortisol for is really electrolyte balance and blood volume needs and blood pressure needs. So cortisol's conversion to cortisone there is going to be very much dependent on that. Whereas cortisol conversion to cortisone in the liver is telling us much more about systemic utilization of cortisol. The liver doesn't care about your blood volume or blood pressure. It's not a mineralocorticoid rich receptor-rich tissue at all. It doesn't have much 11 beta HSD2 activity. In fact, in obesity, it's downregulated in the liver significantly. So if anything, the liver and adipose tissue are converting cortisol to cortisone or cortisone to cortisol based on blood sugar, like insulin sensitivity issues, it's governing inflammation, it's governing the immune activity, it's busy doing other parts of the cortisol story, not blood volume, blood pressure, or electrolyte balance. So really, we're looking at two different compartments of cortisol utilization. In obesity, we tend to see, kind of follow the arrows, cortisol getting converted to cortisone in the renal tubule. And some people postulate that the reason we see that conversion to cortisone more robustly in somebody who's obese is that there's an inherent kind of potassium deficiency that kind of leads to cortisol-cortisone imbalance there. But whatever the reason, we do get higher activity of cortisol to cortisone, and then that cortisone can be reabsorbed back into circulation. And that's why you get this arrow back to the liver and adipose. And that cortisol essentially can be delivered back to, in somebody who has a lot of central adiposity, can be delivered straight back to its captor, to the adipose tissue, which can then reactivate cortisone into cortisol, like in this case, by 11 beta HSD type 1. So the kidney and salivary gland have 11 beta HSD type 2. That's the enzyme that converts cortisol to cortisone. The liver and the adipose tissue, and adipose tissue in particular, has extremely high expression of 11 beta HSD type 1 that reactivates cortisone to cortisol. And that's problematic in that tissue because it adds to that adipose tissue dysfunction that keeps that fat from being able to be lost, essentially. Okay. I do want to make mention of this tetrahydrocortisol preference in the cortisol metabolite. So that suggests an acute inflammation. It's a very acute picture for her, All right. So she's got some deficiencies. Here's her organic acids page. B12 is low in the mitochondria. This is adenylyl B12 form. If she's taking methylcobalamin, if she's taking hydroxycobalamin, these are her levels. If she's got a higher serum B12, this is really telling us about mitochondrial access to adenylyl B12 above all. And, it may be that she really is low in B12 all over the place. Maybe she's not absorbing B12. She is on omeprazole. There may be some work that you can do with the gut to get her better at absorbing B12. You'll notice that the kine and the xan that we talked about earlier are pretty high, not so high that we would say, oh gosh, is she taking tryptophan or something that's, causing a false positive. No, she is not taking tryptophan, and these levels are a little bit high, but they're all high all the way down. Xan, kine, quin. So, we definitely want to be thinking about B6 deficiency, and probably a pretty profound one. And when xanthuronate is elevated in the bloodstream, we know that it can complex with insulin and make it very, very hard to overcome insulin resistance. So let's give her an edge, get the B6 in there, bring the xanthuronate down, takes that off the table, and she'll respond to her insulin sensitizers much better. When quin is a lot higher than kynurenate, and it really is just a 2.5 times higher, it can really signal inflammation. So inflammation, we're not surprised. We've been seeing inflammation all over this report. So nothing new. Pyroglutamate and 8-OHDG, I always like to look at together, and especially when pyroglutamate is high, suggests that she needs some glutathione support. It's a pretty overtaxed system right now, and she doesn't look like we would see in an extreme case of like hepatotoxicity from acetaminophen, where pyroglutamate's in the thousands or something like that, but just a little bit on the higher side. So, her body's working pretty hard right now to keep up with the oxidative stress needs. And arguably, she's got some cell turnover because we've got some DNA in the urine. And so oxidative stress starting to emerge as a part of her presentation as well. Okay. So I'm kind of old school. I still like to do case arrangement on my tough cases or very complicated cases. helps me kind of see where to concentrate. And I feel like that inflammation, oxidative stress terrain is perpetuated by a lot of those cortisol metabolites and dysfunctional adipose tissue, and that's probably the best place to start. So everything else, like the 5-alpha reductase activity and the high androgens and the CYP1B1 activity and the estrogen metabolism, all of that should improve from addressing or getting 3, 5, 10% of her body fat gone. So really kind of concentrating there. Yeah, we could do a 5-alpha reductase inhibitor and help her with her chin hairs, and we can do those types of product supports as a kind of a band-aid, but in the end it's going to be about getting her sensitized to her insulin, getting after the inflammation, getting that initial weight loss, make a big difference. And of course, another way of looking at the case arrangement, I just pulled out all of those findings essentially, and all the things that can lead to those findings. And you can see some themes: insulin resistance, inflammation, oxidative stress, and of course some deficiencies. We don't want to forget those, but over and over and over. But I think the right approach is to bring that adipose tissue dysfunction back under control. So we want to go after the inflammation, the oxidative stress, and the insulin insensitivity in order to do that. So we really want to obliterate that adipose 11-beta HSD1 activity to decrease the cortisol metabolites. Almost across the board, when patients are struggling with weight loss, when you run a Dutch test, you will almost always find high metabolized cortisol or higher metabolized cortisol compared to lower or a flat pattern diurnal-free cortisol, often even. So I just want to dig into this for a minute, and I'll just take a few slides to do that here. First of all, what is 11-beta HSD1, and how does its activity end us up with so much metabolized cortisol? Well, it's an enzyme that is highly expressed in adipose tissue, especially central fat. In fact, 11-beta HSD expression was found to be 2-fold higher in adipose tissue biopsies in that study down at the bottom there, right here. That was a study on 70 postmenopausal women. I know it's kind of an oldie from 2004, but still, they're looking at 11-beta HSD1 expression and how it is higher in this particular cohort. That 11-beta HSD activity generates cortisol and cortisone, which are then metabolized down to tetrahydrocortisol and tetrahydrocortisone by 5-alpha and 5-beta reductases. Those metabolites in the urine increase as 11-beta hydroxysteroid dehydrogenase type 1, 11-beta HSD1 activity increases. So more 11-beta HSD1, more cortisol metabolites. And it's the reason cortisol metabolites can be so high when HPA axis activity can kind of seem so low. It's that regeneration of cortisone to cortisol. Waist circumference, interestingly, is a predictor of 11-beta HSD1. So not BMI, nothing else. Waist circumference is your most significantly associated predictor. So if you have somebody with a female patient who's greater than 35-inch waist, or a male patient with a higher than 40-inch waist, you're probably going to see high metabolized cortisol. We have some modifiable factors that can influence 11-beta HSD1 and some maybe not so modifiable factors. Inflammation, insulin resistance, all the things that we're seeing, oxidative stress, central adiposity, those are all possibly modifiable risk factors. Injury, healing from injuries, and getting after chronic infections. Those can all help decrease 11-beta HSD1 expression and activity. I also think about gut health and getting, butyrate absorption and our short chain fatty acids all in alignment. I think that also may be playing a role too for some people with their high 11-beta HSD expression, especially with those with chronic gut infections or inflammation there. But there's also a collection of genes that have been looked at too, so that like genetic obesity kind of presentation. And I suspect that that may be what this patient is coming with. She's always dealt with disease of obesity, even when she was a little kid. And she is somebody who has espoused a healthy lifestyle for, decades and has always felt like nothing she did registered as, um, helpful to her body composition. So maybe a collection of genes that she's running up against. When you have patients with high 11 beta HSD1 activity, these are the things to be thinking about: fatty liver, insulin resistance, metabolic syndrome. This should just kind of be in your mind. Sometimes when people have acute presentations like an acute migraine or acute COVID-19 or acute, infection, and they're very, very sick, metabolized cortisol will often look really high like this. So you definitely want to tease out like the chronic picture versus the acute picture. And I want to put this idea out there too. I think a lot of us have been through treating adrenals in the past with adaptogens and feeling like nothing is bringing this metabolized cortisol down. I'm using, ashwagandha and relora and bacopa and, jujube and everything, lemon balm, and nothing is bringing this metabolized cortisol down. So all of these here, the high leptin, low adiponectin, the high inflammatory cytokines, the dysbiosis, the insulin resistance, all of these things are pushing the metabolized cortisol higher and pushing that 11 beta HSD activity up. Adaptogens are simply modulating the HPA axis, and some of them have some mitochondrial support as sort of part of what they do. But, the 11 beta HSD1 enzyme hijacks that whole system, and the brain doesn't really know, and maybe doesn't have any idea that, how much cortisol is accumulated there in that tissue. So I think this is why adaptogens alone don't always do the trick. So we have to fix all of these things, That's a big job. First. Okay. Considerations for lowering 11 beta HSD1 can be pharmaceutical, they can be herbal. And I do, there is some evidence that exercise can, remodel expression of 11 beta HSD1. This patient already does a mixture of resistance training and aerobic exercise, and I think she's in a pretty good place with that. It's time for other interventions possibly. So the pharmaceuticals out there that we have been studied for lowering 11 beta HSD1 expression and activity in fat tissue are the thiazolidinediones. Those are like the pioglitazide. That's probably the most famous one. The bezafibrate has been looked at for lowering 11 beta HSD1, and so is Topamax. All of these can be used in the setting of weight loss and high lipids and insulin resistance. In the herbal world, we tend to pull for things like curcumin, bitter melon, green tea extract. Cinnamon has constituents that can lower 11 beta HSD1 activity and help with insulin sensitivity through that mechanism. All the soy isoflavones from genistein, daidzein, equal on down. Rosmarinic acid. So you can imagine, a curcumin, rosemary, green tea formula might be pretty powerful. Quercetin also has some activity in lowering 11 beta HSD1. Few studies investigating weight loss effect on 11 beta HSD1, but there is one. So if you lose weight, does your 11 beta HSD1 activity go down? That's also kind of a no-brainer. You would think that it would, and it does seem to. Stomby, this particular study, they did on two different diets. They did a paleo diet versus kind of a Mediterranean style diet. It's called the NNR diet, but it's a Nordic diet: fish, legumes, whole grains, fruits and veg. I mean, it sounds pretty Mediterranean-y. But the idea was that regardless of the diet, if the patient lost weight, they decreased their adipose tissue 11 beta HSD1 activity at both 6 and the 24-month marks. One of the things that we see with obesity is that adipose tissue has an increased 11 beta HSD1 activity, but the liver 11 beta HSD1 activity is really low. And that can lead to problems that can lead to fatty liver accumulation over time. So what we really want to see is an evening out of that 11 beta HSD1 activity in those tissues. We want it to come up a little bit in the liver, and we want it to go down in the adipose tissue, right? We don't obliterate 11 beta HSD1 in all tissues. We want to really target the adipose tissue. So one of the things that they found was that liver 11 beta HSD1 activity did go up at 6 months. But overall, the adipose tissue 11 beta HSD1 activity went down at 6 months, and it continued to go down at 12 months. So weight loss, sustained weight loss can make a big difference, and it doesn't matter how you do it. So here's what they did, because I think that's what people want to know. What would you do, or what would this provider do for this patient? And we know the treatment focuses on inflammation, insulin, oxidative stress. Here's what they did to double down on all three of those areas. So we knew that weight loss, we wanted that to begin to occur. 3, 5, 10% of the body fat loss. So that physical loss we know is going to help to increase insulin sensitivity, decrease the 11 beta HSD1, really kind of just reset some of those hormonal inputs that maybe she's up against from a genetic perspective, so that her exercise can start actually doing something for her, and so that her diet can actually start feeding her in a way that's, sustains her muscle and her body composition. So this provider actually switched her from metformin, because she had been on the metformin for years and hadn't really changed her body composition, and switched her to semaglutide, which is also known as Ozempic. And anyway, semaglutide is a once weekly injectable. Not everybody's going to want to do it, and it's a high cost out of pocket. So some people won't be able to switch over to semaglutide. I would love for them to work on that accessibility for patients if it really is the be all end all for weight loss. But if the goal is 10% body fat loss by 6 months, this is a pretty safe, studied way to do it. And their plan was to retest the Dutch Complete in 6 months, and that was going to be the cornerstone of their therapy. They also added in a prebiotic and micronutrition powdered drink to restore butyrate and gut terrain and provide some absorption support, since she had so many deficiencies on her organic acids. They did a high B6B complex to correct some deficiencies in the short term, and added in the liposomal glutathione to get after that oxidative stress component that we saw in the organic acids. They also added in, and this is one of my favorite herbal formulas as an anti-inflammatory, that's got curcumin and rosemary, ginger and green tea, and a lot of those anti-inflammatory supports are also 11 beta HSD1 inhibitors. So that's also going to help keep adipose regeneration of cortisone to cortisol really in check. And then the myo-inositol they did in the 4-gram dose in order to support leptin resistance and get those leptin levels down. And I think between all of those inputs, they have a pretty powerful treatment plan. She's only on 1, 2, 3, 4, 5 supplements and a drug. I mean, I've seen people walk out the door with a box full of things. And that, this is more than she's probably going to have to be on for long term. She will probably eventually be able to lose the B complex and the glutathione support, and maybe able to kind of coast on a few key supplements going forward. Diet, they continued on with the Mediterranean diet, but they did work with her on increasing more fiber. They really wanted to double down on the, trying to help her generate more butyrate from the gut. And I think they're considering doing some gut testing. And then they wanted her to continue with her low impact exercises, just given her her current body weight, and that they would reassess her needs at the next visit. And that's our case. And I thought, this gets us all thinking about how we would assess and address our next weight loss patient. I am excited that you joined me today. I hope you found this informative, or at least a little thought-provoking. Thank you for being here with me, and bye for now.